Good morning, good afternoon, and good evening. Thank you for joining this event. My name is Nicole Engelbrecht, and I'm the Head of Communications and Marketing for the Union for International Cancer Control, UICC. And I'm thrilled to moderate this event today and to be joined by an esteemed panel of experts who will lend their perspectives and insights on the topic of advancing age-inclusive cancer care. I would first of all like to thank our partner Sanofi for sharing the commitment to address this challenge and for having organized and sponsored this session. So thank you, Sanofi. Let me start by introducing our panelists. We have Dr. Enrique Soto Perez de Celis, geriatric oncologist and researcher in medical sciences at the Department of Geriatrics of the National Institute of Medical Sciences and Nutrition in Mexico City. And Dr. Perez is also a UICC Young Leader. Hello. Then we have Professor Ravindran Kaneswaran, Senior Consultant and Deputy Head of the Division of Medical Oncology of the National Cancer Center, Singapore. He currently serves as President of SIOC, the International Society of Geriatric Oncology. Welcome, Professor Kaneswaran.
Thank you.
And our third speaker will be Professor Eric Krakauer, Associate Professor of Medicine and of Global Health and Social Medicine at Harvard Medical School, and an attending physician in the Division of Palliative Care and Geriatrics at Massachusetts General Hospital, where he also directs the Global Palliative Care Program. Welcome, Professor Krakauer.
Thank you.
And last but not least, we have Dr. Alexander Zander, Global Head of Oncology at Sanofi, who has more than 20 years of experience in healthcare strategic marketing, commercial leadership, and general management roles at the country and global level. And Dr. Zander is also a member of the Sanofi Genzyme Executive Leadership Team. Welcome.
Thank you.
Thank you to all four of you for joining this discussion about cancer and aging, or more precisely on how to advance age-inclusive cancer care. And I have to be quite strict about timekeeping so that everyone gets the chance to talk, and we have enough time to answer potential questions from our audience. And I encourage everyone to put their questions into the chat. And then at the end of the session, if we do have time, I'll take a couple and pass them on to our panelists. So now, without much further ado, I would like to ask the first question to Dr. Soto Perez. I know you said Dr. Soto is what I can say. The first question goes to you. Around the world, people are living longer than ever before, and we know that comes with an increased risk of cancer. So could you give us an overview of the scope of the global cancer burden, of the global burden of cancer and aging, and how this convergence impacts both patients and health systems?
Yes, of course. First of all, thank you very much for inviting me for this discussion. I think this is a very important topic currently and for the future. So globally, as you said, the number of older adults is increasing at a very rapid pace. Just to give you an idea, in 2010, there were about 500 million people aged 65 years and older globally. And by 2050, this will triple to 1.5 billion. And importantly, most of this increase will take place in developing regions of the world, which I think is a very relevant issue because healthcare systems and cancer care plans in developing regions of the world are ill-prepared to tackle chronic illnesses that come along with aging, including cancer. No? And also about life expectancy, this will increase by 2050. We'll see the global life expectancy go to 74 years. Currently, it's about 69. So people will be living longer. And with this increase in life expectancy, there will come an increase in the burden of non-communicable diseases such as cancer. We all know that aging is associated with a greater burden of comorbidity and also with a greater burden of disability. And this, of course, is a challenge when treating an older patient with cancer, because all of these things need to be taken into account when designing interventions for cancer. And as I said before, many healthcare systems and many cancer control initiatives were designed to tackle acute ailments or focus on younger populations. And many of these initiatives lack this multidisciplinary perspective needed to treat older adults with cancer. And again, this is particularly pressing in developing regions of the world. And we can see that by looking at the incidence to mortality ratio of cancer across the world. And if you see that, you can see that patients aged over 65 who are living in developing regions of the world consistently have worse outcomes when matched with patients from high-income regions of the same age. And worldwide, almost half of the cancer burden is in people aged 65 years and older, and the same goes for mortality. And well, although this may seem like a grim perspective, I also think this is a great opportunity for change and for innovation and for improving the way in which we provide cancer care for older patients, and an opportunity also to increase the geriatric competencies of the workforce, which I think is also another of the main limitations for providing high quality cancer care for older patients. You have to take into account that in many places geriatric is not even considered as a specialty, and many medical schools do not teach geriatrics. So we need to improve the geriatrics training of the workforce as well. And I think this gives quite a good perspective of what we're going to talk about. So we have an increasing population of older adults with an increasing burden of cancer, ill-prepared systems, but great opportunities for improving the way in which we provide care for this growing population.
Okay, then you mentioned there's a need for innovation. What could that be? How would you define an innovative way of addressing this challenge then?
Well, I think there are plenty of opportunities for innovation, and I want to direct the audience to the recently published SIOC priorities for the improvement of geriatric oncology, which we published in Lancet Oncology earlier this year. And I think that there are ways in which we can design models of care. I think that the next step is designing models of care that are adaptable to the resources available at each site. So resources stratification is very important. Innovative models can be created through the use, for example, of digital technology. There are great initiatives looking at conducting geriatric assessment and delivering geriatric assessment interventions through telemedicine, which is a potential solution. There are other technological advances, such as the use of sensors or patient-generated data, patient-reported outcomes to improve the outcomes of this population when providing cancer care. Also, international collaborations, and I think that UICC and SIOC have a great part to play in that, creating not only north-south collaborations in which people from low and middle-income countries go to high-income countries, learn how to do stuff, and then go back to their country, but also collaborations between low and middle-income countries to generate models that can actually then be replicated in high-income countries through reverse innovation. So I think that this is a field that has an enormous potential. And in a way, we are all geriatric oncologists because most of our patients are over 65 or older patients nowadays. So we need to prepare to treat them and to adapt our care to their needs.
Professor Kanneswaran, I'd like to move over to you and hear your perspectives. We know that aging patients with cancer face unique challenges. We've just heard it again. We also know that these challenges impact caregivers and have broader implications on societies and economies. And this is precisely a focus of an analysis conducted by KPMG with SIOC supporting as a member of the steering committee. Could you already to tell us more about the initial findings of this study?
Thank you. And again, I would like to thank the organizers and UICC specifically for getting SIOC involved in this. Gives me great pleasure to share with you and discuss some of the questions that you had asked about. I think just to kind of highlight some of the things that Enrique or Dr. Soto had mentioned earlier, I think clearly, older adults are different. They're unique, right? They have so many issues that they have to deal with that younger adults don't have to, including comorbidities, physical fitness, mental state. And on top of that, you throw in cancer and treatment that's going to be toxic. It's definitely going to affect their quality of life. And this impact extends beyond just the patients, also to the caregiver. And in a broader scale, you think about the community, you think about the country, and the economy. So it was quite timely that Sanofi actually commissioned KPMG to work with a number of global oncology partners. This included SIOP, UICC, the Global Coalition on Aging, or GCOA, and the Chinese Anti-Cancer Association. So these four societies got together, worked with KPMG, formed a steering committee, and the goal was to estimate the economic burden of cancer and aging on societies. The purpose of the study was actually to help raise awareness of this rising health challenge caused by the convergence of cancer and aging, which Dr. Soto had very nicely described, and to further demonstrate the need for global policy solutions to address the unique needs of this community. Now, the study looked at 3 regions, so it's the United States, EU5, and China. So it wasn't truly global, but it was focused because obviously, it was a pretty challenging study to do in the first place. And what we did was we looked over the next 2 decades and identified gaps in policies and investments related to age-inclusive cancer plans. Now, I'm just going to go through some top-line highlights of the key findings from that study. So firstly, the study assessed economic burden of geriatric cancer by looking at 2 different metrics. One was the disability adjusted life year, and the other one was caregiver burden. Now, disability adjusted life year is an established measure of disease burden, and it considers both time lost due to early mortality and non-fatal disability conditions. And what the study found was that cancer burden will increase by about 80% over the next 2 decades, with the biggest increase seen in breast cancer, which is about 107%, stomach cancer and esophageal cancer, both about 90%. Now, the economic cost of cancer for the studied regions have been assessed to be about 1 to 2% of the GDP in 2020. Now, by 2040, this forecasted number is going to be 5 times in China. When I talk about ballpark figures, we're looking at about 200 billion now, rising up to 1 trillion by 2040. And for the EU5 region, we're also going to see a doubling of cost. And and this is going to be, and as I mentioned to you, I gave you an example, it's going to cost billions of dollars. Now, the second part was caregiver burden. Now, this is an important consideration and provides an estimate of the loss of economic contribution when caregivers are unable to participate in the workforce because they're caring for an older adult with cancer. Now, based on the economic modeling that KPMG had used, it indicates that while cumulative cancer incidence is highest in China, the caregiver burden is highest in the developed countries like EU5, followed by the US, and then China. This is based on current estimates, and of course, these numbers are going to be, a lot higher in time to come. And what kind of estimates we're looking at? EU5, 83 billion, US, 46 billion. All these I'm quoting is in US dollars, and even in China is 20 billion. So, looking at all this from a big picture view, we come up with some kind of recommendations on how to address some of these issues, and actually they overlap with what was mentioned by Dr. Soto. So I'm not going to go through everything in detail, but what he mentioned about the 12 priorities that was published this year by SIOP actually encompasses that solution. And so key elements of those includes education and training in geriatric oncology, formulation of a national oncogeriatric program, enhancing the use of geriatric assessment tools, educating people about it, how to use it, how to optimize it, and enhancing knowledge about treatments of older patients with cancer, including encouraging enrollment of older patients into clinical trials, which is something that has been neglected for many, many years. So those are some of the elements, and I think Dr. Soto has, described a lot of these things in great detail, so I'm not going to repeat those things, but that's basically it.
So you mentioned that the study proposes the use of geriatric assessment tools, for example, and geriatric evaluation into oncology decision making. And I know you're also actively involved in graduate medical education. Is that, for example, already part of the curriculum for students who want to become oncologists or not?
So right now in Singapore, it is. What we are trying to do is encourage this globally as well, because it's like just like what Enrique had mentioned earlier. The key thing is for oncologists everywhere to recognize that these are important skill sets for every single oncologist to have, because the bulk of their patients are older adults. So it needs to be part and parcel of their training program. And unfortunately, it's not there in every single, oncology training program out there. But that's where SIOC comes in. We want to educate people. We want to help them with training. So we have advanced courses running currently in 2 different places in Europe, and most recently this year we started in Canberra. And we're going to start these advanced courses all over the world, hoping to train the trainers and for them to go and disseminate information on how best to use geriatric assessment tools to optimize care for the older adults with cancer.
Thank you for sharing these facts and findings already. These preliminary results are also available in the resource section of the platform, in the section When Cancer Grows Old. So I encourage the audience to look that up if you want to read a bit more about these findings of that important study that will be published fully later. I would like to move to Professor Krakauer and would like to ask my next question to you. So we're hearing about the challenges faced by the aging cancer patient, and also we're hearing about the stark gaps in cancer policies and plans that are needed, that need to be closed really to address these needs. So from your perspective, how do the inequities faced by older individuals with cancer compare to the inequities faced by other patient groups?
Thanks, Madam Engelbrecht, and thanks for the organizers for inviting me. As Dr. Soto mentioned, there's a lot of vulnerability, especially in low and middle income countries. The very poor, very vulnerable, those with the rural poor are especially vulnerable, and older people are also vulnerable. So there's certainly vulnerability, partly because of the demographic shifts that are occurring, both epidemiologic shift that Dr. Soto mentioned and demographic shifts where more older people are alone or less often cared for by their children, who are often moving to cities or mobile and moving away from home. So I think that older cancer patients certainly are very vulnerable, and this vulnerability needs to be considered in national cancer control planning. I assume that I should say something about the International Cancer Control Partnership, which exists to assist especially low and middle income country ministries of health to design and implement national cancer control plans. So if I may, I'll say a few words about the International Cancer Control Partnership, or ICCP, of which I've been a member for a while. It's organized by the UICC, but with many other organizations, including the International Agency for Research in Cancer, the International Atomic Energy Agency, the African Organization for Research and Treatment in Cancer, the Sociedad Latinoamericana del Caribe de Oncología Médica, and many others, the USNCI, ASCO. And it includes experts in most fields related to cancer, although I don't know that we have a geriatrician or even a geriatric oncologist on the ICCP. Perhaps I'm wrong. Hope I'm wrong. But includes certainly medical oncologists, radiation oncologists, pathologists. I'm a palliative care specialist, as you mentioned, epidemiologists, and global health and policy experts. And the point is to assist any Ministry of Health from any country with really any aspect of cancer control planning and creation of national cancer control plans using available data based on local need and available resources, and also assistance not only with drafting national cancer control plans, but implementing them and with quality assurance.
Yes.
Go ahead. Well,
Yes,
a couple of comments specifically about geriatric oncology and policy. I'm not a geriatrician, nor am I an oncologist, but some things come to mind from many years of working, especially in low and middle income countries. One is ageism or discrimination against older people. Older people, I think, are at risk for substandard or lack of access to cancer treatment just because they're old. And I think this needs to be avoided in planning. Older people can also benefit from cancer treatment and certainly from cancer prevention and early diagnosis. I should have mentioned at the beginning that I don't take any money from private industry, so my comments are not based on influence from industry. And I would add that I think it's very important for ministries of health to avoid granting insurance coverage for expensive anti-cancer medicines, of which there's a proliferating number, if the poor cannot afford even the copay for such medicines, unless basic cancer treatments are available free of charge. I'll say that again. Unless basic standard cancer treatments, tamoxifen, for example, very basic treatment for breast cancer of some kinds, unless basic cancer treatments are available free of charge or easily affordable, I think using national resources to pay for very expensive cancer medicines that are only accessible by the very rich, because only the rich can afford the copay, should be avoided. I would also add that there are very difficult clinical decisions for older patients because, as Dr. Soto and Dr. Canes-Varan mentioned, there's a frailty, there are comorbidities such as dementia, renal failure, common comorbidities in older people, which make decision-making difficult, when to treat, how to treat, with what to treat. And I think it's even becoming more difficult as targeted therapies and immunotherapies become available, which sometimes have fewer side effects or can be even used in patients who would not tolerate standard chemotherapy. I think it'd be great for WHO to create a guide on integrating palliative care into geriatric oncology. Palliative care is absolutely essential part of geriatric oncology. It's an essential part of any oncology, but especially geriatric oncology. And it includes symptom control, helping with these difficult decisions, providing psychosocial and spiritual support, and especially important, I think, in these difficult decisions about cancer treatment for older people are exploration and understanding of patients' values, which vary from culture to culture. Last point that I'll make is about avoiding building cancer care silos. Most patients who need cancer, who have cancer, are in the community, and they can receive a lot of the care they need as part of primary health care. So I think there needs to be a very careful consideration of close collaboration and integration of cancer care and primary health care, because primary health care can address the minor problems of cancer patients locally, can help prevent financial catastrophe for families by addressing minor problems locally and referring only when necessary, helping to avoid lost follow-up for cancer treatment. And also palliative care can be provided as part of primary health care. So I'll stop there.
Well, thank you very much, Professor Crocker. Building on what you just said, maybe Dr. Soto, do you want to give us an insight how this plays out in your country, in Mexico? What is the status of age-inclusive cancer planning and cancer care in your country?
Well, sadly, there is none. I mean, Mexico is one of those countries that doesn't even have a well-structured cancer control plan, and the cancer care initiatives in the country are lacking a geriatric perspective. No, and in our country, and we're recently starting to study this, most medical universities do not give geriatric training to medical students, and this is not included in most oncology fellowship curricula. So, and we are an upper middle income country with a growing population of older adults, and still this is happening. No? What we currently have is, at our hospital, we have a geriatric oncology clinic. We are a public hospital, and we provide care that's free of charge for patients. And we have a multidisciplinary geriatric oncology clinic. And we are trying to use technology to provide care to patients living in the community. So in less developed regions of the country, in the southeast of the country, for example, where there are many challenges for providing cancer care, etc. And I just want to touch a little bit on the ageism issue, because I think this is extremely important. I'm very glad it was mentioned, because ageism comes from the healthcare system, from the research community that's not including these patients, from the caregivers, from society, and even from patients themselves, who feel like if they are old, then they shouldn't be getting any treatment at all. This is a normal part of life, and that getting treatment for when they're old is unnecessary. So the World Health Organization recently published an excellent review on ageism, which I think everybody should read. And I think this is one of the things in which organizations like UICC have a great part to play, no? Tackling ageism all across the board, in all stakeholders and key players in cancer care. COVID-19 is a great example of how ageism became an everyday practice. No, we saw this with rationing of resources. We saw this on the media with a study about social media and COVID-19 and older adults. And ageism was rampant in social media. So this is a problem that our societies have, and we need to tackle it, because if we are lucky, we will be old. So this is something that will happen to all of us. So for me, this is a crazy thing to do, to be ageist, because it's discrimination against your future self.
Yes, that's very, very true. And I see Professor Kaniswaran nodding as well. Maybe you can also give us some insights from your experience in Singapore. I know this is also culturally different, but it would be interesting to hear, what are your views, what are your experiences on this?
No, thank you, Nicole. And I think it's great to share, our different perspectives. So Singapore is a developed country, and you would have thought by now we have this, extensive cancer control plan. And actually, the reality is we are still in the process of developing it. But the good news is, because we are developing it, we've learned, from how these cancer control plans have been developed in other countries and how it's functioning. We are able to incorporate some of the key elements that and one key thing we're discussing today is on geriatric oncology. So geriatric oncology is part and parcel of that plan. It's still not fully finalized yet, but one of the key elements is to incorporate geriatric assessment for every single older adult that presents to our cancer centers. So in my cancer center itself, we have been doing this since 2007. So 14 years we've been running geriatric oncology services for our older adults. Of course, with limited resources, it was restricted to just selected groups of patients whom we felt needed it more than others. So we use screening tools to try to sieve out and identify those who truly need the geriatric assessments to be done on them. So that's been running for a while. So we hope that the cancer control plan will come to fruition, and we'll be able to, and we'll have geriatric oncology incorporated as part of it. Just to add to what Dr. Soto had mentioned, I fully agree with the issue of COVID-19 and how it highlighted what he said absolutely perfectly spot on, which is on the daily ageism, right, with rationing of resources. So SIOG actually formed a task force to address this. And initially, the goal was to highlight the issues that older adults suffered from during this stage, the discrimination, where as long as you were above a certain age, it didn't matter how fit you are or whether you had a pretty long runway in front of you in terms of lifespan. All that didn't matter. As long as you're above a certain age, you just didn't get the appropriate treatment that would have helped you prolong your life. And that was really unfortunate. So with these we came up with a statement, guidance on how to treat these patients. And then most recently, another one on vaccination as well, and the role of vaccination in the older adults. A lot of them sometimes have a lot of taboo, misinformation, fake news out there, and they don't get their vaccines. And that's been a huge problem. You have cancer and you're old and you don't get vaccine. That's really bad. So yeah, I'll just end there.
So there's clearly a lot to do to address this challenge. And before I give the floor, or rather the screen, to Dr. Zander, maybe one last question to you, Professor Krakauer, which comes from the audience. If you could leave the audience or the listeners with one piece of advice to help address the aging cancer burden in their own communities, what would it be?
I think that's very difficult to answer because cultures differ, the clinical situation differs. I would say that it's important for older people to be valued and respected, and on the one hand, to avoid ageism, as we've been discussing, and as Dr. Soto described it very well during the COVID epidemic. So many older people died unnecessarily. On the other hand, there are also this respect also requires, I think, a rethinking of some traditional values. And I'll give one example. In the Confucian world in East Asia, the cultures heavily influenced by Confucian thinking, filial piety is an extremely important value. And this has often been interpreted as do everything to treat older people, their illnesses, and to keep them alive as long as possible. And the flip side of ageism is insisting on potentially toxic treatments that may be more harmful than beneficial by the patient's own criteria, just out of a feeling of filial piety. So I think as in the age of invasive life-sustaining treatments, including cardiopulmonary resuscitation and mechanical ventilation, and also of cancer treatments with many different adverse effects, perhaps for many patients, filial piety might entail protecting them from interventions that might be more harmful than beneficial, rather than sort of reflexively providing invasive life-sustaining treatment and toxic treatments. It's all about respecting older people and exploring and trying to understand their values.
Thank you very much, Professor Krakauer. And I'd like to give this screen to Dr. Zander, Sanofi's Global Head of Oncology. Dr. Zander, you say it's your passion to transform the lives of people affected by cancer, and that keeps you up during the day and sometimes up at night. So I think that's probably a feeling that all the panelists share with you. And could you lend us your perspectives on our topic today and the very rich interventions that we've just heard?
Yes, of course, and thank you, Nicole, and thank you to today's diverse panels of speakers for the great dialogue around these key issues and inequities facing aged people with cancer, and the need for innovative and inclusive cancer policies that are responsive to those needs. And we are really proud to sponsor such an important discussion. I mean, we all know that aging people with cancer and their families face unique challenges. Sometimes they lack specific age related treatment and prevention guidance. Of course, they have additional health problems and comorbidities, and sometimes even the lack to kind of personalized information, resources, or post-treatment support is missing. And as many of the speakers pointed out, of course, during COVID-19, the pandemic has really brought these challenges into stark focus as we consider the disproportionate burden on older individuals, particularly those living with cancer. And through our When Cancer Grows Old initiative, Sanofi's commitment is really to address these challenges and to be a partner with UICC or others around the world to really elevate the need of older cancer patients, including in the global policy agenda, and also leveraging the UN's Decade of Healthy Aging. And as mentioned by Dr. Kanesvaran, we are also supporting a study done by KPMG, and he highlighted some of the highlights already, but it's looking at really the societal impact by 2040 if no action is taken to address this intersection of cancer and aging, as well as the impact on policies and investments that are needed to really develop age-inclusive cancer plans. And this study, which will be released on World Cancer Day next February, will complement guidance from the International Cancer Control Partnership and others to really hopefully help all of us, including governance, the pharmaceutical industry, to ensure age-inclusive national cancer plans are being supported. So again, thanks a lot, Nicole, for moderating. Thanks a lot for the speakers for this great discussion. Stay tuned for the full KPMG report coming next February during World Cancer Day. And until then, I encourage you to visit the ICCP's website and other websites to learn more about national cancer control plans and how they can help to inform responsive, inclusive policies. Thank you very much.
Thank you. And I would like to thank all panelists for sharing their insights today and the audience for joining us. I know that we did not have enough time to cover all questions that you probably still have. And I'd like to encourage you to continue the discussion on the Summit platform, to reach out to each other today or tomorrow, and to help strengthen the collaboration on this very important challenge of cancer and aging. So thank you very much, and good evening, goodbye, wherever you are joining us from.